Quick disclaimer before you listen. The World's Okayest Medic Podcast is an educational and commentary platform produced and recorded by me. What we say on here is not endorsed by any of our employers, and we are not speaking on behalf of our employers. Our commentary is our own. Finally, remember to follow your local protocols. All right, I'm here with Collin. Groathaus, right?
Yeah, Groathaus. Groathaus.
Already
Close
fucked it up.
Close
You're a nurse practitioner. I met you at Resus X. And why don't you tell us about what you do and what you're here to talk about?
Yeah, I'm a critical care nurse practitioner right now in Cleveland, Ohio. Working for a large medical center. I work in the community site where the nurse practitioners have a pretty high level of scope, pretty autonomous, function at a very high level. Before that, I was a critical care nurse for 6 years. So a lot of critical care experience, a lot of passion for critical care education. But happy to jump on with you, man.
Awesome. So why don't you tell us about the topic you wanted to discuss?
Yeah, I mean, you brought it up, man. I saw you post something about flash pulmonary edema or sympathetic crashing acute pulmonary edema. And I said I'd love to hop on and talk about that.
Absolutely.
Something that you guys as medics, like pre-hospital, bring in a lot to the ER, and as an ICU team, we're called because these patients look really sick, and with the right interventions, they can get better pretty quickly. So we see it a lot in the hospital. We see it a lot in the emergency department, and wanted to hop on and talk with you about it, man.
Do you see it mostly in the ICU, or do you get called down to the ER to consult on those patients?
Yeah, so usually these are patients that are rolling into the ER that are in pretty big distress, and where a lot of times we're getting consulted. In our small community hospital, limited resources in the emergency department as far as help. So a lot of times when these patients look really ill, they're calling us and saying, "Hey, can you come check them out?" They're probably gonna have to come to you in the ICU. So hopefully by the time they get to the ICU, we got them a little more stabilized.
Yeah, hopefully. I think we do a pretty decent job of it pre-hospitally. I don't know what the services out like you are, but I think pre-hospital people generally know, like, yes, CPAP, nitrates.
Yep.
But once we drop them off at the hospital, I think that's where the knowledge gap begins for most pre-hospital providers, because when I jumped from just doing straight up pre-hospital, like being a 911 paramedic, to learning the critical care paramedic stuff, I was like, oh, holy crap, there is a lot that goes on with these patients after we drop them off. So why don't we just say I respond to a guy who had an acute onset of shortness of breath. He's got, actually had this patient yesterday. He's got rails all the way up to his clavicles, low pulse ox, hypertensive, tachycardic. I put him on CPAP, give him nitro, and I bring him to the hospital, turn him around a little bit. Now you get him. Why don't you take it away? Like, what's your pathway? What do you think?
Yeah. So, I mean, you said it perfectly there. These patients usually look pretty bad when you guys see them. They're in distress. A lot of times they have this feeling that they're dying. They look like they might be having a massive MI. Like, that's a lot of times what the ED thinks when they get there. That's our first thing we're ruling out. But what you guys do pre-hospital, the CPAP, non-invasive, BiPAP, whatever you have, nitrates work awesome. And then the initial resuscitation or initial stabilization in the emergency department or ICU is very similar to that. We crank up that non-invasive as much as they can tolerate, decrease that preload, decrease that afterload, and we give them large dose nitrates. Sometimes you'll see people who don't see this as much. In the ER, newer providers, start these nitro drips once we get them on IV nitro at very low rates. A lot of times these hypertensive people can tolerate 1,000, 2,000 bolus and large doses, 300 micrograms, a minute, and get that pressure down. Those two things in alone right there are going to help improve the patient pretty quickly, what you guys are doing before the hospital and when they get there.
I get asked this question a lot. How, when you say you're going up on the PEEP and on the IPAP too, since you guys are probably using BiPAP instead of CPAP, how much are you going up at a time?
So it's all kind of like respiratory or provider discretion, or how much the patient can tolerate. As you know, a CPAP, when you're getting high levels on CPAP alone, those patients are starting to get a little uncomfortable.
Sure.
That's when we usually switch them over to BiPAP. But just based on body habitus, how much distress this person's in, you might start them at 10/5, and you might pretty quickly titrate that up to 20/8, 16/8, and just see how they're responding to it. That extra pressure, usually just decreasing that preload to them, helps them feel so much better so quickly.
Can you explain how the positive end expiratory pressure increases or decreases preload and afterload, because we're in school. I think they do a poor job in paramedic training banging on the fluid part that the alveoli are filled, and that you're distending the alveoli, which opens up surface area for gas exchange. But I don't think people appreciate the alveol or the afterload and preload reduction.
Right, right. So, like our normal respiratory system is a negative inspiratory system, negative pressure system. So when we breathe in, that's a negative force. You drop your diaphragm. That's how you normally function. When we put someone on positive pressure, we now create every breath as positive. We're pushing the pressure in. When we push the pressure in, we increase their intrathoracic pressure by a significant amount. You know, if you're giving them a lot of pressure to push that breath in, that increase in intrathoracic pressure causes a little bit of collapse of their IVC, which leads to less blood coming back into the heart. If your person's really dehydrated or your person's really volume down, that can be detrimental to them. You know, if you put them on a lot of positive pressure and their fluid down, you can really drop their blood pressure. These people who have a ton of extra preload and fluid, a ton of extra afterload, when you decrease that return to the heart, it can really help their blood pressure. It can offload that heart a little bit, allow them to have some forward flow. Similar with the afterload part, you know, you increase that thoracic pressure, make it easier for the left ventricle to pump forward when there's less fluid kind of coming into it there. So
Cool.
these patients can really benefit. When these patients have these blood pressures at 220, you know, these patients who miss dialysis for 2 sessions and they're grossly volume overloaded, putting them on positive pressure can work a lot better than the nitrates sometimes to decrease that stress on the heart.
100%. It's like an instantaneous
Yeah.
reduction. Now, you brought up fluid overload. There are things I am exceedingly good at explaining as an EMS educator, and then there are things I am very bad at explaining. I am very bad at explaining the fluid overload. Like, it's one of those things that, like, up here in my brain, it all makes sense, but me trying to explain it, it just comes out as a jumbled mess. Do you mind explaining why a lot of these patients are way fluid overloaded?
Yeah. So the interesting part about this, you know, sympathetic crashing pulmonary edema is some of these patients are really fluid overloaded, and some of them can be pretty euvolemic. Um, I think we see this a lot in the hospital setting. I don't know if you feel this way with EMS. It is a lot for us in my community that I work in. A lot of missed dialysis people. Um,
Yes.
Patients might skip 2, 3 dialysis sessions. Those people usually are grossly fluid overloaded. They're not making urine. They don't take diuretics at home to manage that fluid status. They skip a couple dialysis sessions. They put a ton of stress on that LV and RV, and and their blood pressure's high at baseline. So now they have all this circulating volume. They have increased catecholamines. They're having more distension of that LV. It starts to back up into their pulmonary system and cause pulmonary edema. So when you treat these patients with non-invasive and nitrates, ultimately for them, that helping them the most is end up going to be volume removal. You know, if they're 5 liters up over the past week, you know, you need to get some fluid on for them. Some other people may not be completely fluid overloaded. They might just have such high afterload from some other stressful event, you know, whether that's infection or an MI, as well as viral illnesses, anything that caused a stressor, catecholamine surge. You get really, really high blood pressure, and that LV can't push forward. It backs up into your pulmonary system, but they may not be super volume overloaded, despite seeing some pulmonary edema on your X-ray. Once you treat their blood pressure, treat them with non-invasive, they might not need aggressive volume removal or diuresis.
Yeah, that's a great point. It's not always volume overload. I remember being a younger medic and having our medical director do a ride along, and this patient, they weren't full blown like scape like we're talking here, but they definitely had some pulmonary edema and congestive heart failure. And he took one look at him and was like, he's got a GI bleed. I was like, where the hell are you pulling a GI bleed out of with this guy with rails? And he told me, like, well, he said he was feeling dizzy and passed out yesterday. And he's like, he's probably had this slow bleed. He's having some catecholamines. His whole left ventricle can't keep up with it. It's starting to crap out. That's exactly what it was.
Oh,
Interesting stuff. So I had a young EMT riding along with me yesterday when we had this CHF patient, and she asked me the excellent question of, well, what causes this? And my first thing was like, we have to rule out that he's having a giant MI, because that's, in my mind, the first thing is going to take out your left ventricle. But you mentioned dialysis. What are some other common And I know it's not always a single cause. I know there's often a constellation of things leading up to it. But what do you often see? Because this is the stuff we don't see as EMS providers. So
Right.
yeah, what do you
Yeah.
see with your
Yeah,
patient?
so I think your most common causes, like you said, rule out an MI. Anything that took out that left ventricle, acute heart failure. Dialysis sessions a big one we see. Poorly controlled hypertension. I mean, these patients who normally have a blood pressure of 160 to 180, they might be on a couple antihypertensives, and for some reason they couldn't get their prescriptions. They missed their doses. Now their blood pressure is 240. Massive increases in afterload like that. Drug abuse. People that do heavy cocaine use will have a significantly elevated blood pressure. You can get cocaine-induced MIs, but those people can get pretty rapidly elevated blood pressure, causing this acute pulmonary edema for them. Those are the big ones that I think we see a lot, at least in my community. I think any like initial stages of sepsis, viral illnesses, COPD exacerbations, anything that is going to stress your body out, that you're going to get this big catecholamine surge in the first initial acute phases, can really cause a lot of high blood pressure, catecholamines, this vicious spiral to give you pulmonary edema.
I'm glad you brought up COPD because that's another area of EMS education that it's, and I get it. I'm not shitting on our EMS educators. EMS education is taught in a modular format. It's a great way of disseminating a lot of information in an efficient period of time, in an efficiently in a short period of time. But it's got its limitations, and one of those is that I think it teaches us to compartmentalize things. So we approach a respiratory distress patient, and by the way you're trained, you're thinking, is this asthma? Is this COPD? Is this CHF? Is this pneumonia? And sometimes it's a combination of all of them.
Yeah, it really is. I have a physician I work with, and one of the things he says all the time is, a patient can have as many disease processes as they damn well please,
Yeah, that
and they really can. And a lot of times when they get to the ER, you guys, you might see this patient, they might be in SCAPE, they might be in COPD. The treatment's going to be for pretty similar. Non-invasive is going to be the best thing for them. If they get NEBs, that's fine. If you decrease their blood pressure, that's okay. Like whatever makes them more stable. When they get to us, even in the ICU, we might be treating 2, 3 things at the same time, and while we give them a couple days to kind of differentiate what they actually have. So we may be treating with some steroids and some NEBs. We may be giving them some diuresis, some dialysis, and we may be throwing it all at them because it's not a clear picture all the time.
Yeah, actually brought up my next point, diuretics. They've largely been taken out of EMS protocols because uh, that has generated more misinformation in EMS because people think, oh, well, they took diuretics out of our protocols, they must not like be useful in CHF. And it's like, no, they are useful. But the reason is that we don't have a chest x-ray. We don't have lab work. We don't have a lot of it's coming around. Most places don't have POCUS for the lung yet. So
Right.
we may end up giving a diuretic to some dehydrated pneumonia patient and make them much worse. But you
Sure.
talk about diuretics and goals and what you use in these patients.
Yeah, if we know they're fluid overloaded, this is someone that once they got to the hospital, we treated this acute pulmonary edema with BiPAP and nitrates, and they're getting better. And now we've done our workup, and this patient's, up 30 pounds in the last month, and they have heart their failure with a reduced EF of 20%. They have obvious signs of volume overload. We're going to give them, the diuretics is just the dosage is whatever gets them to get them to a volume status you want them to get to. That's kind of going to depend on if they take diuretics at home. Those people are going to be a little more resistant. Giving them 20 milligrams of IV Lasix if they take 40 twice a day at home isn't going to do much for you. Our general rule of thumb in the hospital is whatever you take at home, we usually at least double that to start.
Really?
40 of oral Lasix at home is equivalent to 40 of IV Lasix. IV is a little double strength for the bioavailability. So if they take 40 of Lasix oral at home, I'm going to give them 40 of IV and see how they respond. If they're not making a lot of urine, I might hit them with 80 of IV the next, 6 hours later.
Gotcha.
But whatever diuretics get them to start making urine, and then we set a goal for them. We might want them to be 2 liters negative the first day, or maybe more than that if they're very volume overloaded. We've had patients up 80 pounds in 6 months that, we might diurese 40 pounds off of them in a couple weeks during their hospital admission if they can tolerate it. So some of these patients are just profoundly volume overloaded. A lot of these volume overload patients are usually your patients with heart failure with preserved EF is what we see in the hospital. Those patients with an EF of 60, but they have a lot of uncontrolled hypertension. They have a lot of that ventricular remodeling, and they are very prone that LV just can't fill. So it really backs up into that left atrium and pulmonary system, and they benefit from a lot of diuresis.
Gotcha. Yeah, I was thinking yesterday, our old protocol 15, 20 years ago was Lasix. It was 40 milligrams or their daily dose.
Yeah,
If you could figure it out. Now I remember looking at this guy, I was like, this guy's clear cut CHF. He looks like a tick that just fed. Like a little bit of Lasix would do him great. How you talked about if they can tolerate all that diuresis. What like how aggressively are you diuresing these patients in the acute phase?
that's all patient to patient dependent. Like I said, it kind of depends on how much volume are they up. What's their overall volume status look like? If they have signs of both pulmonary edema and peripheral edema, really high elevated BNPs, which can be a little tricky in the setting of renal failure or dialysis patients. Those are always going to be a little elevated. Echo findings that show four chamber dilation. If you have obvious signs of just profound volume overload, we can be pretty aggressive on these patients. And their body will respond pretty well. More diuretics doesn't necessarily mean more diuresis. Giving a higher dose of Lasix doesn't mean you're technically going to diurese more. It's kind of like a light switch. If you give the right amount to get the kidneys going, they're just going to dump the fluid that your body wants to get rid of. So a lot of times, sometimes we might do 40 of Lasix to these naive patients, and they might be 5 liters negative in a 12-hour shift. As long as they're not getting a significant alkalosis from contraction of those kidneys, we're not getting like electrolyte derangements. We can just keep diuresing them.
That's awesome. When do you start thinking about pressors and inotropy?
Yeah, I mean that's just going to depend. I mean, if we're talking scape, these people usually show up really hypertensive. We're talking just heart failure in general. You're going to start thinking pressures like anybody who's profoundly hypotensive. I mean, if you got blood pressures maps less than 60, I think that that you're not going to be perfusing your kidneys. It's always fine to start them with a little norepinephrine.
I think a better way for me to have gone into that question was me saying, yeah, like obviously if they're in cardiogenic shock and that's going to be signs of CHF with hypotension, I guess I could have better asked it and said, from your perspective, when do you see, aside from just the normal test answer of hypotension, like what signs do you see that your patient is going into cardiogenic shock before they're hypotensive? And
Right.
when you would start thinking about pressors?
Yeah, cardiogenic shock it's interesting. It can be a little tricky sometimes. You'd see your septic shock people. These people are usually febrile, they're tacky, and they look very very dry on exam. Your cardiogenic shock people, you get if you guys ever seen that like 4-box diagram of what kind of stage of cardiogenic shock they're in, or what their volume status of cardiogenic shock in. You can Google it. It's very interesting. You can have these patients that are cold, clammy. They're going to be altered mental status. They're going to be in distress. Those are going to be your like extremis patients. Those are going to be the ones you said are volume overloaded. They're obviously hypotensive. They have really high elevated lactates, and they're going to need some pressors and inotropes. Then you can get some gray areas where you have patients who might be tachycardic and pretty normotensive, but their body's responding, to something happened. Maybe they had a massive MI. I've had a patient that has been like this before that had a large MI, was a little unstable, so he didn't get taken to the cath lab right away. He wasn't a STEMI per protocol, but had very large end STEMI. Came to the ICU to get resuscitated. When I saw him in the morning, he's had a heart rate of 130. He had a new bundle branch block. He was normotensive. Blood pressure was like 130 over 80. But he was in obvious distress. He's tachypnic to 40. He had rails. He had pulmonary edema, elevated troponin, elevated lactate, worsening metabolic acidosis. And this patient was in profound cardiogenic shock, despite having a pretty normal blood pressure.
Yeah, it's just like it's just like a trauma patient.
Yeah, exactly.
I mean, you see that with your gunshot wound patients. They're pale, they're clammy, they're altered, they're irritable, they're agitated, and they're tachycardic. And you take their blood pressure, and you're like, "What the hell?" It's like 138 over 70, and it's like you tell a student clearly, don't be deceived by that blood pressure. This patient is in shock.
Absolutely. And these patients, if they're normotensive like that and their cardiac output's low, you have POCUS or echo to confirm it. Starting inotropy on them, dobutamine, milrinone is going to be a very good place to start. That's going to decrease that afterload for them and give them some of that inotropy for forward flow. I would be very hesitant, and we are very hesitant in my shop starting any inotropy, dobutamine, milrinone on anybody that's already hypotensive.
Can you explain why to people? Because
Yeah,
when I teach the critical care stuff, they say those are pressors and you're fixing their cardiac output. Like, why would your blood pressure drop?
right. Yeah, it's a good question. And dobutamine, it's what we usually use here. Some places opt for milrinone. Those kind of work so well in cardiogenic shock for people who have a really high afterload and a really high volume status, because it decreases that afterload, causes slight vasodilation, and it gives you some inotropy, so causes some forward flow, which makes it really nice for that left ventricle to push against less resistance and have a little help squeezing. If you're putting that on somebody that already has a MAP of 55, you're not quite sure what their systemic vascular resistance is or what their afterload is. Kind of like we said before, a patient can have as many problems as they want. You might have someone in cardiogenic shock, but maybe they were septic to begin with. So maybe they already have vasodilation, or maybe they've been in extremis for hours, which can cause a surge response and vasodilation. If you jump straight to dobutamine, sometimes in these people, you're going to drop that afterload too far, and you're really going to make them more hypotensive before causing any good. So I think norepinephrine is always a great place to start if a patient's hypotensive. You can give them a little bit of beta activity, give them a little bit of alpha squeeze. You can get them to a normal tensive state. Then we can kind of reassess how their shock's doing and if they're improving.
Yeah, norepinephrine's like the goat of
Gold.
depressors. I mean,
Yeah,
it's just,
absolutely.
I mean, it's great. Do you ever use dopamine?
Very little in our shop. I think mostly if someone's in. Oh, we really only use it nowadays in my ICU is if someone's in cardiogenic shock, strictly from like a complete heart block.
Okay.
We usually opt for dopamine or epi. Dopamine is just in our Omnicell. It's easier for the nurses to override and grab. So if someone has, symptomatic bradycardia, that's usually when we just throw some dopamine at them.
Are you using the dopamine and heart block because of the rate increase?
Yeah, we get some chronotropy from it. We'll try to push the rate up, just enough to get them normotensive again until we can get them a temporary or a permanent pacemaker.
Yeah, a lot of EMS services still have dopamine because we have medical directors who have been working since like 1960, and they still like, oh, I've been using it for years with no problem.
Yeah. Yeah, it works. I mean, it works okay for bradycardia. I wouldn't opt for it as a first line pressor in sepsis or cardiogenic shock. But if you're just looking for, chronotropy and heart block, it seems to do okay.
Yeah. What about can you explain real quick ventricular remodeling? Because I know you brought that up, and I know that 9 out of 10 paramedics are listening to that and going, "What the hell is he talking about?"
Yeah. Something that happens, you see a lot of times, like I said, in these patients with HFpEF or heart failure, the preserved ejection fraction. It also happens in your reduced ejection fraction people. But, say someone who has uncontrolled hypertension for years and years, that left ventricle is just pushing against so much afterload. When your systolic's in the 180s all the time, your left ventricle is working overtime to push blood forward. Over time, those catecholamines and that heart muscle, because it's working so hard, start to remodel and they start to get very, very thick. So you get this left ventricular hypertrophy, which I'm sure a lot of all medics have probably heard of at some point. That LV wall gets so thick that it leads to less filling effect. So you still have good squeeze, and you might be squeezing fully, kissing walls, but it just can't fill as well because those walls are so thick it can't hold as much volume, which leads to a big decrease in stroke volume. So then when you get these patients that for some reason got really hypertensive, missed dialysis, had an illness, had a COPD exacerbation, now your LV is pushing against less or more resistance. It can fill less, and it starts backing up into those lungs.
Can you reverse that?
You can't really reverse the remodeling, but you can prevent further remodeling. When you get people beta blockers, you're going to decrease their heart rate. You're going to allow for more filling, longer time in diastole, which allows for longer time in diastolic filling, which will help. You can give them ACEs and ARBs. And people with the reduced ejection fraction, you now use Arnis or Entresto. We see a lot has good reviews or good literature. But decreasing that blood pressure, giving them, ACEs, ARBs, beta blockers are first line therapies to try to prevent that remodeling from happening further.
Gotcha. Well, that's a lot of information.
And I'm not a cardiologist, man. I've hopped on with my cardiology friends to help learn all this stuff too. So
Where did you learn this stuff?
A lot from school. A lot from just
What
asking questions.
which NP, like what kind of NP program? Did you do acute care?
Yeah, acute care, adult gerontology, acute care, at the Ohio State University in Columbus, Ohio. Here, good program. I worked at the Ohio State University Wexner Medical Center, so that allowed me to have some pretty great ICU experience. Level one trauma center, level one stroke center, um, ECMO. Everything that you see at a large tertiary care center was done there. But I think with you guys, with us in the nurse practitioner field, nurses, even physicians. Education doesn't stop, right? There's new stuff coming out all the time. There's more to learn. And one of the best things you can do is ask questions. And when I was a nurse, these residents, these fellows, ICU attendings or ER attendings, if there was something I didn't know, the best thing to do is ask. Other people that know more, cardiologists, your experts in fields will explain things to you. Retain that information and look it up on your own time. Just doing self education is going to make a huge difference in our field.
Yeah, I always say never hesitate to ask a question because people feel like they're dumb if they ask a question like, oh, I should know that already. And I guarantee you, just from the teaching I've done, there are 3 other people in that room who have no idea what the instructor is talking about or just straight up haven't seen before. I'm sure if you went to a neuro ICU, there's going to be stuff you've never seen before. And
Yep.
what may be everyday common knowledge for a neurointensivist is going to be like mind-blowing brand new information for somebody as experienced as you in your role.
Yeah, absolutely. There's always, critical care medicine, emergency medicine, pre-hospital. There's so much that goes into it. You're going to see something new almost every day. So, if you don't know, that's not something to be ashamed of. Asking questions is how you grow in this field, and doing your own education. I love your posts on
Thanks,
social
man.
media, and you're posting great articles and great literature reviews, and the time you put into like actually review that information, evidence-based practice, and to put that stuff into practice is how we get better at our jobs and how we improve patient care.
Are you going to Resus X this year?
I got a child on the way, so
Oh,
I'm gonna.
congrats.
Yeah, thanks, man. I'm
Yeah,
looking how Paul's looking.
that uh that definitely will cramp your lifestyle
Yeah.
for
Yep.
yeah, that's gonna set you back a few years. We're finally
Yeah.
at the point now where I got I got asked to go, and by the way, shameless plug, if any April 27th, 26th, 27th, 28th, 29th, I got asked to go to the New York City Fire Department's like urban search and rescue medicine conference. And it was kind of a last minute thing. And I said to my wife, I was like, oh my God, we're at the stage in our lives where we can entertain, like, yeah, we'll go. Like,
Yeah,
screw it.
absolutely.
It's so much better.
Absolutely,
So
man.
that's awesome you're having a kid, but I do.
Yeah, it's exciting.
Yeah.
It's
So one last question I have for you that I just thought of: when for the critical care transport people, you're in a community ICU. When are you thinking about sending these patients out?
In the community ICU, we really our resources out there are fairly limited. We do some like open heart surgeries. We take care of STEMIs. But when we're talking about patients in cardiogenic shock that are going to need mechanical support, balloon pump, Impella, usually these patients are going to be best suited to fly to our tertiary care center,
Mhm.
just for advanced heart failure specialists.
Can you guys implement? Can you do the Impella and balloon pump there?
Yeah, so we can put impellers and balloon pumps in. We'll use balloon pumps occasionally for our STEMI patients that are having a lot of arrhythmias. Just need a couple of hours or a day of reperfusion, but that aren't in shock. Now, if we got patients that are going to the lab with a massive MI and they're coming out on Impella and maybe a pressor or two, these are patients that probably need to be at a center that can rapidly cannulate for ECMO should
Sure.
they start to compensate. We don't have a cardiac surgeon in house, so it makes it hard if they decompensate on max Impella at 2 in the morning. We're kind of out of options to really support them. So we try to get them to our tertiary care center where, should they have worsening symptoms, they're with the right people that can intervene quickly.
Awesome. Well, Colin, thanks so much. Do you have anything else you'd like to add, or?
No, man, it was great having me on. I appreciate everything you post and the education you do. I appreciate all you guys in the pre-hospital medicine, making our jobs easier every day. So it was great to come on and talk with you.
Thanks, man. All
Yeah,
right,
for sure.
everybody. Well, that's Colin. I'm sure you will see him back.
Yeah, hope so, man. Have me back anytime.
Yeah, no, you're like Melody. Like the first time I had her on, I was like, damn, I gotta have her on more.
Melody's great.
Yeah, let me stop this.
All right, man. Appreciate it.
Hold on. Step